السلام عليكم، يعطيكم العافية. أنا الدكتور ضياء السويدات، أخصائي الطب النووي والعلاج في النظائر المشعة. Uh, Today's case is about thyroid cancer. This is a case of papillary thyroid cancer, previously treated by radioactive iodine. However, the patient by MRI discovered to have liver lesions with a solitary left lung nodule. So, they sent the patient for FDG PET CT scan for assessment of these lesions. Overall, papillary thyroid cancer, as we know, most of the papillary of the well-differentiated papillary thyroid cancer are radioiodine avid because they have a sodium iodide symporter, so they have increased radioiodine uptake, which and we can use this in the treatment of the papillary thyroid cancer by radioactive iodine 131. However, if we expect that this patient might have a poorly differentiated process, we image the patient by FDG because the poorly differentiated lesions in the cancer will be FDG avid and take high FDG activity, and we know this is poorly differentiated lesion, and the well differentiated lesions will be radioiodine avid. However, they will be negative on FDG PET CT scan, and this is very important because if these lesions are negative on the FDG, so we know that there is no poorly differentiated process in the metastatic lesions, and we can give the patient another radioactive iodine, maybe as empiric therapy, even in some cases with negative iodine. The negative activity of the FDG give us a good result with a good prognosis and possible response to radioactive iodine therapy. So let's start for assessment of our case. As we see, the lower right image is a maximum intensity projection image, which shows the normal distribution of the FDG. We start with the brain, which is intensely there is physiological FDG activity with the brain parenchyma. We should decrease the intensity for better assessment of the brain parenchyma. However, as we know, the assessment of brain parenchyma by FDG is very low due to intense physiological activity. We should carefully assess the head and neck for a better assessment of the lymph nodes, because as we said, if the lymph nodes are FDG avid, they might have a poorly differentiated process, and the response to radioactive iodine will be very poor. So we should send the patient to another modality of therapy. So as we see, the lower left images is the PET, the upper right is the CT, and the upper left is the fused PET CT images. As we see, there are few mild hypermetabolic. Mild hypermetabolic, it's good, it's better than moderate or intense hypermetabolic. The mild activity here is good. So the cervical region is the first place that that the metastasis will go to in the papillary thyroid cancer. There are bilateral cervical lymph nodes, as we see in the level 3 of the neck. However, their metabolic activity is mild, which is good. So they don't have intense FDG activity. So we can expect that they do not have significant poorly differentiated process inside. There are mild hypermetabolic bilateral level 3 cervical lymph nodes, and this is the right one, is the prominent one. We should assess the site of the primary tumor or the site of surgery, because it's the first site to for tumor recurrence. The patient had a previous total thyroidectomy. This is the thyroid bed, the surgical bed, and there is no evidence of hypermetabolic concerning lesions at the site of surgery. The brain is normal. This is head and neck status post total thyroidectomy with no evidence of hypermetabolic concerning lesions at the surgical bed. There are mild hypermetabolic bilateral cervical lymph nodes. The prominent one on the right side with size of 1.4 centimeter and SUV max of 3.3. As we say, the SUV max standardized uptake value, which reflect the activity inside the lesions. The 3.3 means it's not significant activity, which is good so far. It assesses the mediastinal structures. No evidence of hypermetabolic concerning mediastinal lymph nodes. There are only few bilateral axillary lymph nodes with a preserved fatty hilum and non-significant FDG activity. They are likely reactive in nature. This is normal physiologic activity in the heart. And let's go for assessment of the lung parenchyma. No evidence of hypermetabolic nodules. However, there is a nodule here. We can see on the CT images, maybe it's clear here. There is left lower lung lobe pulmonary nodule. Its size about 1.3 centimeter axially with non-significant FDG activity. We should mention it. Despite it lack the activity of the increased FDG activity, still it's suspicious for metastasis, and however with well-differentiated metastatic pulmonary nodule. So absence of FDG activity in patients with thyroid with well-differentiated papillary thyroid cancer does not exclude metastasis. It only excludes the poorly differentiated process inside the metastatic lesion, which is very, very important point. The patient has, as we see in the CT window, there are multiple hypodense lesions in the liver with non-significant FDG activity. However, can we exclude the metastasis? No, we can't. Why? Because it might be well-differentiated metastatic thyroid cancer and it will not take any FDG activity. So we should mention these points in our reports. As we talked previously, the chest, there is left lower lung lobe pulmonary nodule measuring about 1.3 by 1.2 centimeter with non-significant FDG activity. No evidence. These are the normal template of the chest region. No evidence of any lesions in the chest, abdomen, and pelvis. There are multiple bilobed. They are located in both lobes of the liver with non-significant FDG activity, and they are very large, 6 centimeter axially. And everything in there are normal renal activity. This is excretion of the radioactive material. This is somehow enlarged uterus with minimal diffuse FDG activity. It's likely physiological in nature. It's likely due to menstrual cycle, and no evidence of hypermetabolic concerning lesions. We should assess the bone because the first site of distant metastasis in thyroid cancer is the lung, and the bones is the second site of metastasis. What the nature of the bone metastasis? They are lytic lesions. They are not sclerotic. For example, there are some few sclerotic lesions in the left pubic bone, as we say. They are intense sclerotic lesions with non-significant FDG activity. They are likely bony island because of two reasons. The first one is the house field unit for these lesions is high, which goes with a benign process, and the second one is the thyroid cancer gives a lytic lesion, not sclerotic lesions. So and they are sclerotic, so we can exclude them, and they are not metastatic. Is there any lytic lesion or the hypermetabolic bone or bone marrow lesion? No. So the musculoskeletal system is normal, and this is our report status post. This is the conclusion. No evidence of hypermetabolic concerning lesions. I didn't write there is no evidence of hypermetabolic local recurrence because there may be small recurrence. However, it will not take activity because of its differentiation process. There are mild hypermetabolic bilateral cervical lymph nodes. They need further evaluation. Metastatic process cannot be excluded because, as we said before, they might be well differentiated. And this is the most important point. Multiple liver lesions with solitary left lower pulmonary nodule. All of them have non-significant metabolic activity. Still, a well-differentiated metastatic process cannot be excluded. Thank you for listening, and see you in the next case, inshallah.